got maybe about 4 minutes for questions. There are microphones throughout the room if anybody has any questions. While people are coming up, I'll have Elizabeth ask a question, I think.
Yeah, well, while people are coming up, my first question, one, by the way, excellent, really great. So excited to have you guys here. Excellent job. I was going to ask Lisa, because we talk a lot about FibroScan. Those of us that perform it know it's so subjective and we can make it be whatever we want. If people could come to the microphone stands to do their questions, please. Yeah. So the question I had for you, we dismiss FibroScan a lot for being easy to mess with. What do you think about a FibroScan less than, that's a low score in a person who has a BMI of 35?
That's a great question. I think, I want to look at the criteria. Was the IQR greater or less than 30%? What does the imaging quality look like? So am I looking at, the propagation map and I'm like, oh, wow, these are not parallel lines. It doesn't, the shear wave does not look good. So, again, I want to make sure it meets quality criteria. I know the recommendations generally are if they have a BMI greater than 35, the VCTE is not going to be helpful. If it's low, again, I'm not sure if I would look at all those other criteria to decide whether or not I believe it.
For your non-invasive testing, what about like for our facility, we don't have MRE capability, we have the VCTE, but certainly on your super morbidly obese patients, kind of what is your because in terms of doing all of the algorithms and things and you don't have the capability of MRE or the VCTE based on BMI, where do you go with those patients?
Fantastic question. I really think that you're talking about real world problems that we see, right? So that's where I would look at different non-invasive tests. So I'd look at my FIB-4. I would look at my ELF score. We've had several patients recently at UCSD that because of confounding factors, they wouldn't fit in the MRI or they were too claustrophobic. I can't have a VCTE or whatever. We've done an ELF score.
Okay.
The ELF score is really good at helping us identify patients at risk for fibrosis stage 2 and 3.
We got a question over here.
I had a quick question in regards to that as well. So we live in an area that doesn't even have elastography. 3 hours away is the nearest one. I've never heard of ELF, but we've always used FibroTest. Is that pretty comparable, or do you feel like the ELF is a better test?
Okay, thank you. I think the ELF test is the one that's been studied the most. It has a higher positive predictive value. I would go with ELF.
Okay.
Lisa, I also have a question for you. I practice at some of my clinics are in very rural areas in Kentucky, so we have very limited resources. So would you feel comfortable diagnosing a patient with MASH with serologic testing only, like an ELF score?
Yeah, we have. So I would look at the cardiometabolic risk factors. So really look at the patient profile. Do they have diabetes? Are they obese? Do they have hypertension? So look at the cardiometabolic risk factors and then ELF, and then I would be okay.
If they have clinical picture and ELF, we don't have to biopsy.
No, I wouldn't. So no, I think I would be okay to treat them with Resmetirom. If you look at the FDA approval, you don't need biopsy, but we all know that steatohepatitis is diagnosed based on histological evidence, but we don't need that to treat a patient if we have the things that I just mentioned.
So just for time, or go ahead.
The only thing that I would add to that is just to ensure that we are completing a full chronic liver disease workup in that patient, just to make sure that we aren't missing an autoimmune hepatitis or something else that could be causing the liver enzymes to be elevated. But I agree with Lisa that a biopsy is not necessary in order to diagnose MASH.
We'll do one last question.
On the Resmetirom, has anybody in the panel used kind of in that like F3, F4 in that kind of gray area?
So we have a Resmetirom clinic, and so it's not FDA approved for F4. So I would say, look at the AST, look at the ALT, look at the platelets. Does this patient really have a profile that you think they're more F4? Look at the spleen. Are there other things that you want to look at? Because if they're F4, if I'm leaning towards F4, I'm not going to treat them.
Okay.
So So with that for time, we'll go ahead and conclude, but the speakers can certainly answer any questions after. So thank you to all our speakers and thank you guys for attending.